Hi, welcome to the Doctors in Training Pharmacology Review course. I'm Dr. Brian Jenkins, the President of Doctors in Training, and our goal here at Doctors in Training is to help you be the best medical professional you can possibly be. Whether you're studying to be a physician assistant, or nurse practitioner, we feel like this pharmacology course is the right course for you. So I hope you enjoy this lecture, and I know that it's going to help you learn more, save time, and be awesome.
Hi, I'm Dr. Chris Lewis. I'm one of the chief educators here at Doctors in Training. Today, we're discussing a pharmacology lecture on CNS stimulants. So let's get started. So today, we're going to talk about two major categories of central nervous system stimulants, the psychomotor stimulants and the hallucinogens. Now, the first will cause excitement and wakefulness, decrease fatigue and euphoria, all the wonderful things that we wish we had in life. And the second will cause profound changes in mood and perception. Now, there are many examples of using many of these meds for therapeutic reasons, but more often these are used and abused and used recreationally. And it's important for us to know these things because when someone comes into you tweaking, you want to know what they're on and what to do about it. So first, let's talk about the psychomotor stimulants. And our first group of drugs are going to be the methylxanthines. And this includes caffeine, theophylline, and theobromine. Now, caffeine is the most widely used psychoactive substance in the world. It's found in beans, it's found in leaves, it's in the fruit of some plants. It can act as a natural pesticide that can paralyze and kill certain insects. Some of you might be able to do that with your breath, with the amount of coffee you drink. We get most of our caffeine from the coffee bean, though we also get some from the tea bush leaf, and we also get it from the cola nut. And that's a nut that was originally used for a lot of the flavoring in our soft drinks. So we should know sort of the general amounts of caffeine that either we ourselves are drinking or that our patients are drinking. A single shot of espresso has somewhere between 80 and 100 milligrams of caffeine. The traditional drip coffee has somewhere between 100 and 125 milligrams of caffeine, but this is in a much larger volume, a volume of about 120 milliliters compared to about 30 of the espresso. Most people don't realize this, but dark roast coffee actually has less caffeine than lighter roasts of coffee. Decaffeinated coffee is not completely decaffeinated. It'll have somewhere between 5 and 15 milligrams of caffeine. Tea has much less caffeine, but it does have small amounts of theophylline and theobromine. Both of those are methylxanthines. And tea is far more variable in its caffeine content. You know, some teas like green tea have quite a bit of caffeine, where other darker teas that you would assume would have more caffeine have relatively little. Soft drinks have somewhere in between 10 and 50 milligrams per 12 ounces. Energy drinks are extremely popular right now, things like Red Bull and Monster. Now, Red Bulls have about 80 milligrams of caffeine. The Monster, the large ones, the 16-ounce cans, have somewhere around 160 milligrams of caffeine. Chocolate will contain small amounts of caffeine, and it'll also have theophylline and theobromine. A typical 28-gram serving of chocolate, like a Hershey bar, has as much caffeine as a cup of decaffeinated coffee. So let's talk about the mechanism of action of the methylxanthines. So it works on adenosine, and more specifically the adenosine receptor, and it antagonizes these receptors. So adenosine has been theorized to suppress neural activity in the brain. And there's evidence that adenosine receptors interact with the dopamine system. And this is which we think is responsible for the reward and arousal feelings that we get from drinking caffeine. Now, there's a second mechanism. There's an increased cyclic AMP and cyclic GMP, and this is due to an inhibition of phosphodiesterase. And ultimately, this may allow an intensification or a prolongation of the effects of epinephrine, and this will give us increased sympathetic tone and feelings of alertness and being awake. So let's talk about the action of caffeine or the methylxanthines on our bodies. So first we'll start with the central nervous system. So again, it's a stimulant. It restores alertness. It can decrease fatigue. Cardiovascularly, high doses can even cause increased inotropic and chronotropic effects. So you'll get increased heart rate, you can get increased contractility of the heart, and subsequently increased cardiac output. Renally, so this, especially caffeine, can act as a mild diuretic. Gastrointestinally, you'll get increased secretion of gastric acid. So you've got to be careful with patients with gastroesophageal reflux disease or peptic ulcer disease. They really should be avoiding all forms of caffeine because it's going to increase their gastric acid and decrease the pH in their stomach. And then in the lung, so caffeine has mild bronchodilation effects. Theophylline, which we'll talk about a little bit, actually has been used as an asthma medication, though it's been mostly replaced by the beta-2 agonists and other asthma drugs. So therapeutically, how do we use these things? Well, we just mentioned theophylline is no longer a preferred treatment for asthma, but it does have bronchodilation effects. It also has some anti-inflammatory effects as well, which is thought to be a major contributor to its positive asthma effects. One interesting thing is apnea of prematurity. So little babies in the NICU who are premature, when they're prone to apnea, sometimes we'll give caffeine. More often than we'll use theophylline, but occasionally theophylline is used. And the way this works is it tends to increase ventilator responsiveness to carbon dioxide. So that increasing carbon dioxide maybe as a result of apnea, your body tends to increase its respiratory response while on caffeine. It can also be used in labor and delivery. So a relatively common side effect of spinal anesthesia is that some women may develop a post-lumbar puncture headache. And in these cases, an IV infusion of caffeine can be used to treat the headache if other measures fail to relieve the pain. So first, obviously, we'd probably try things like acetaminophen or maybe even NSAIDs. Next, pharmacokinetics. Well, these are well absorbed orally. They distribute well throughout the body, including the brain. It will cross the placenta, and it's also found in breast milk. It's metabolized in the liver, and it's excreted in the urine. Adverse effects. So at moderate doses of caffeine, you can get some insomnia, some anxiety, a little bit of agitation. I think we've all felt a little bit of that after one or two mini coffees. At higher doses, you start getting nauseous, and you can even have emesis, and ultimately you can have convulsions. Now, a lethal dose is about 10 grams. So you've got to drink about 100 cups of coffee very, very quickly to get to that lethal dose. So it's really hard to actually overdose and kill yourself on coffee. Now, probably the biggest side effect is when you try to stop drinking coffee or drinking caffeinated beverages. So you can get lethargy, irritability, and headache. And this can occur after consuming, on average, about 600 milligrams of caffeine a day. So that's the equivalent of about 6 cups of coffee. And if you try to stop doing that abruptly, you're going to get all these symptoms. Now, theophylline overdose is something we need to mention very quickly. It can be very impressive. So there's a very narrow therapeutic window for theophylline. And that's one of the reasons why we don't use theophylline near as often for controlling asthma or COPD like we used to. So an overdose in theophylline can result in vomiting, abdominal pain. You can even get hypotension. It can even result in death from ventricular arrhythmias and seizures. Next, we're going to switch gears over to nicotine. Now, nicotine is the second most commonly used stimulant behind caffeine. Now, we're not going to talk extensively about the dangers of cigarette smoking. We all know that it's a major risk factor for coronary heart disease. It can be instrumental in increasing your risk for various cancers, and it's the primary cause of chronic obstructive pulmonary disease. But how does nicotine work on the body? So nicotine binds to nicotinic acetylcholine receptors in the central nervous system. Increased levels of dopamine tend to be what's responsible for the euphoria and the relaxation and also the addiction caused by nicotine consumption. And nicotine activates the sympathetic nervous system as well, and this will result in an epinephrine release. So let's talk more about the actions of nicotine on specific organ systems. So central nervous system. So low doses produce euphoria, arousal, and relaxation. So there's sort of this combination of pepping you up but also relaxing you. It can improve attention, improve learning and problem solving and reaction time. Sounds like things I need for my lecture. Nicotine is an appetite suppressant, so you will hear people who, especially when they try to quit smoking, they say they gain a lot of weight. Well, it's true because nicotine is an appetite suppressant. At very high doses, you can get even central respiratory paralysis and severe hypotension. Cardiovascular, so stimulation of the sympathetic nervous system will result in an increase in heart rate and blood pressure. You'll get vasoconstriction of the peripheral vasculature, and this can also worsen peripheral vascular disease. Now, nicotine will also decrease coronary artery flow, so this will certainly affect patients with angina. That's usually the first thing we tell anyone who has any coronary heart disease. The first thing you need to do is quit smoking because it's going to kill you. Pharmacokinetics. So these are highly lipid-soluble molecules. They do cross the blood-brain barrier. It takes about 7 seconds for nicotine to reach the brain when inhaled, and the half-life is about 2 hours. The average smoker takes in about 1 to 2 milligrams of nicotine per cigarette. Now, things like chewing tobacco, dipping, snuff, all that type of stuff, it usually provides a greater amount of nicotine, but it's hard to quantitate because it depends on how much you use and for how long. Now, it's metabolized in the liver by cytochrome P450, and that's good to know. And this is an interesting fact. So, glucuronidation and oxidative metabolism of nicotine is inhibited by menthol. So this increases the duration of action of nicotine. So that's why they make menthol cigarettes, because it improves your nicotine action. So what are the adverse effects? Well, you can get irritability, you can get tremors, GI cramping, diarrhea, tachycardia, you can get increased blood pressure. It's unlikely that a person can really overdose themselves on nicotine through smoking alone. Although you can get some intoxication through excessive use of nicotine patches, gum, nasal sprays, or oral inhalers, but these are all intended for smoking cessation. So of course you'll hear these stories of someone who's trying to quit smoking and they've put 17 patches on their body, and lo and behold they get sick. Now, though this is still an unlikely situation, you can actually spill a high concentration nicotine, liquid nicotine onto your skin, and this can actually cause acute intoxication or even death. Nicotine is readily absorbed into the bloodstream following dermal contact. So in pregnancy, you can increase the risk of spontaneous abortion. You can increase placental abruption, placental previa. Preterm labor and low birth weight can occur. So that's why we tell all of our pregnant women, please don't smoke while you're pregnant, because that can lead to some very serious problems. So what happens to you during withdrawal? So you're trying to quit smoking. So you'll be irritable, you'll have anxiety, you'll be restless, you'll have difficulty concentrating, you'll have headaches, you'll have insomnia, and on top of that you'll start gaining weight because you're no longer reaping the benefit of the appetite suppression of the nicotine. It is very difficult to quit smoking. It's similar, if not worse, than quitting things like heroin and cocaine. Now, there's lots of different ways of quitting smoking. There's hypnosis, there's psychotherapy, there's acupuncture, and there's also nicotine replacement. So there's patches and gums and inhalers and lozenges and even electronic cigarettes, and these all are modes to get nicotine into your body. Now, they tend to give you lower dosages than a regular cigarette. But again, this can be controlled by the patient, and if they want to put 14 patches of nicotine on them, then they can. Now, there's another medication called bupropion, and it's an antidepressant. It works on dopamine, and it can also reduce the cravings for cigarettes and nicotine. Now, there's a relatively new medication to help people quit smoking called varenicline, and this is a partial agonist at the alpha-4 beta-2 neuronal nicotinic acetylcholine receptor. That's a mouthful. And it produces less euphoria because it's only a partial agonist on this nicotinic acetylcholine receptor. It helps with nicotine cravings, and it'll actually attenuate the rewarding effects of nicotine. So if a person is on the medication, they stop smoking, but then they go back to smoking again, they tend not to feel as good on the nicotine this time around. Now, the side effects are very important because you'll discover a lot of people don't tolerate this medication very well. The side effects will include very vivid dreams. Some people have horrible nightmares and they simply won't take the medication because their sleep is altered. More importantly, there can be some serious mood changes. So people can have some severe depression and even suicidal thoughts where they had never had mood problems before. So you need to warn patients of these problems. And if they start to feel bad inexplicably, then you need to get them off the medication. Next, we're going to move on to cocaine. So it's a very common abused drug, and it's highly, highly addictive. So it's an alkaloid found in the leaves of the coca plant, and it's indigenous to the Andes. So indigenous communities in South America have chewed the leaves for 1,000 years. And they were using this for medicinal purposes, but I imagine that there was probably some addiction involved as well. Now it's been extracted and it's been used in clinical medicine for over 100 years. So back in 1859, there was an Italian doctor, Paolo Mantegazza, and he went to Peru, and after he got there, he witnessed firsthand the use of the coca by the natives. So he proceeded to experiment on himself, and upon his return to Milan, he wrote a paper, and there he claimed that cocaine had some beneficial effects, and this is what he said. It's beneficial for a furred tongue in the morning, flatulence, and whitening of the teeth. So since then, we've honed in on what exactly cocaine does for us. So back in 1879, it was actually used to treat morphine addiction. And then in 1884, it was used as a local anesthetic. And in fact, Sigmund Freud actually tried to use it as an antidepressant. And there's a nice quote that even says that, even after repeated uses, there's no addiction apparent with this medication. Now, mechanism of action for cocaine. So there's an inhibition of the uptake of dopamine, serotonin, and norepinephrine. So remember that. There's an inhibition of the uptake. So the blocking of the dopamine transporter, or the DAT, increases the dopamine concentration in the limbic system. And this is what appears to be what's providing the euphoria. So dopamine causing euphoria, remember it's from the reduction of uptake. So the long-term use of cocaine can then lead to a depletion of dopamine, and this will result in severe craving. And this is what then obviously leads to the severe addiction of cocaine. So let's talk about how it affects the body. So it's again a stimulant, so CNS increases awareness. You get a feeling of well-being and euphoria. Now, unfortunately, you can also get hallucinations and delusions of paranoia or grandiosity. Increases in motor activity, and at high doses, it'll cause tremors and even convulsions. And you can also, if you get to very high levels, get to respiratory and vasomotor depression. Again, there's sympathetic stimulation, so you're going to have an increase in norepinephrine. So how does that affect your adrenergic system? So you'll get tachycardia, you'll get hypertension, you'll get pupillary dilation, and peripheral vasoconstriction. Ultimately, you'll get high blood pressure with this. Also, relatively unique to cocaine, though we'll talk about another medication that causes this as well, hyperthermia. So you'll get impairment of sweating and cutaneous vasodilation, so you can't get rid of your heat. And also what's bad about this is that your perception of heat is also decreased. So you're sitting there getting hyperthermic and you can't even tell. So let's talk about therapeutic uses. So let's talk about legal therapeutic uses. So the only thing you can use this for is for local anesthesia. So this can be applied during eye, ear, nose, and throat surgery. Pharmacokinetics. So most of the time this is a self-administered drug, and it's chewed, it can be snorted intranasally, it can be smoked, the freebase form called crack can be smoked, and people can also inject this. The peak effect is at about 15 minutes after an intranasal snorting, and the effect can last about 1 to 1.5 hours. Now, you can get more rapid onset and a shorter duration for the IV, so you can inject it and get it into your system quicker. And the same thing with smoking, so you can smoke the freebase form, the crack, and you'll get a faster onset of symptoms and a more exaggerated symptom as well. Now, this can lead to increased incidences of overdoses, and there's also greater addiction potential for the IV in the smoked version. Cocaine is rapidly metabolized by plasma and liver cholinesterases. Now, there's a metabolite that can be excreted in the urine that can be checked by our urine drug screens. And this is benzoyl ecgonine, and it's used to detect when people are on cocaine but then deny it. Let's move on to adverse effects. So anxiety. So a response after taking cocaine can be insomnia, sweating, paranoia, nervousness. You can get really amped up on cocaine, obviously. Now you can get a secondary crash. So once the cocaine wears off, you get exhausted. So people will have really impressive crashes and go sleep for 20 hours or so. Now depression can also be an adverse effect, and this is usually after you're coming off of cocaine. So this is more of a withdrawal problem, and you can have a period of mental depression and agitation for a good long while. Cardiovascular, so while you're on cocaine, hypertensive crisis, so very, very high in-organ damage as a result of malignant hypertension. Cerebral vascular hemorrhage, myocardial infarction, cardiac arrhythmias. Chronic use can lead to cardiomyopathy, and this is worse when cocaine is taken with ethanol because it can form this compound called cocaethylene, and this tends to be even more cardiotoxic. A common problem is perforation of the nasal septum. So due to the vasoconstriction effects of snorting the cocaine, you can erode the septum in your nose. So withdrawal, you can have physical and emotional depression. You can have suicidal thoughts, you can have severe fatigue, and we've already talked about the exhaustion and the crash that you can get immediately after taking cocaine. Let's talk a little bit about the overdose problem. So someone comes in and they have extremely high hypertension, they are having chest pain, they're in terrible shape, they're not doing well. Well, what can you do to help prevent any major catastrophe? Well, the first thing we grab are the benzodiazepines, and these are sedatives, and they're the first thing we try to usually alleviate the cardiovascular symptoms. Now, if severe cocaine-induced hypertension continues, then you can use a medicine called phentolamine. And phentolamine is an alpha blocker, and this can block alpha receptors that are activated by the increased levels of norepinephrine, because that's how cocaine works. It's shooting out all this extra catecholamine into the body. Now this is an important fact. You do not want to use beta blockers to treat a cocaine-induced hypertension or cardiac arrhythmia, because if you use the beta blockers, then you're going to have a potential unopposed alpha stimulation. And this can lead to coronary vasoconstriction and in-organ ischemia.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
He once performed an MRI with a microwave and a tuning fork. His breath is so refreshing that it can be used as an antidepressant. When he's on call, the other hospitals close because there's no need for them.
Because of my iron will, I have no vices, other than compulsively saving patients' lives. But tell me this, what causes the addiction to nicotine? That's right, my friends, increased levels of dopamine.
Hi, I'm Dr. Mike McInnes, and I'm going to go over the answers to quick review number 1 with you. So let's get started. First question, how much caffeine is considered a lethal dose? Well, a lethal dose of caffeine is 10 grams. Now remember that equivalent is 100 cups of coffee, so it's really hard to get a lethal dose of caffeine through coffee. Thank goodness. Second question, what are some withdrawal symptoms of caffeine? So caffeine withdrawal can cause irritability, it can cause lethargy, it can also typically cause headaches. Next, what's thought to cause nicotine addiction? So nicotine has a lot of different actions. It acts on nicotinic acetylcholine receptors, obviously, and activation of nicotinic receptors in the sympathetic ganglia will cause increased sympathetic activation, so you get increased release of epinephrine and norepinephrine. But the effect of nicotine that leads to addiction is thought to be increased levels of dopamine. Next question, list some dangerous effects from cigarette smoking. So we know that cigarette smoking is bad, but specifically, why is it bad? What does it do to you? Well, cigarette smoking is first of all a major risk factor for coronary heart disease and other atherosclerotic disease. So smoking cessation will lower your risk of MI by about 1/2 in just 1 year. And the risk is down to that of a non-smoker in as few as 2 to 5 years. So if you smoked for 20 years and you quit smoking, in 5 years, your risk of heart attack is as if you'd never smoked. Now, your risk for other disease doesn't drop that quickly, or may not drop at all. It's important to note, it's not just nicotine in cigarettes. There are hundreds and perhaps even thousands of chemicals in cigarette smoke. So nicotine probably doesn't contribute to atherosclerosis. It's probably tar and other things. Nicotine may contribute to endothelial dysfunction. It may increase norepinephrine, as we talked about, and so that can cause some problems. Rises in blood pressure and vascular tone, which may trigger atherosclerotic events, but nicotine itself doesn't directly contribute to atherosclerosis. So what else does cigarette smoking do to you that's bad? Cigarette smoking is a primary cause of COPD, chronic obstructive pulmonary disease. It also contributes to the development of other pulmonary diseases such as asthma and plain old pneumococcal pneumonia. Again, it's not the nicotine that does this, but it's the other toxic substances in tobacco smoke. And just as an aside, don't buy the hype that smoking tobacco is bad for you, but smoking marijuana is perfectly safe. We're going to cover THC a little later on in this lecture, but marijuana smoke has about 3 times more tar than tobacco smoke. It has about 50% more carcinogens than tobacco smoke. And marijuana cigarettes, joints, aren't filtered like a typical cigarette is. So, you're getting more of the toxic stuff right into your lungs to do more damage. On the other hand, nobody smokes 20 marijuana joints a day like you can smoke a pack of tobacco cigarettes a day. So you're not getting as much smoke overall, but that marijuana smoke, cigarette for cigarette, is much worse for you. One more thing about COPD and smoking. Once you have COPD, you never get rid of it. COPD is a progressive disease. It's going to get worse even if you quit smoking. So we said for risk for MI, you quit smoking, your risk of MI is going to go back down to that of a non-smoker. If you have COPD because you smoked, you're still going to have COPD when you quit smoking, whether it's 5, 10 years. And that COPD is going to get worse because it's a progressive disease. However, it's going to get worse more slowly if you quit. Or to put it another way, it will get worse faster if you continue to smoke. So what else does cigarette smoking do to you? It increases your risk for various cancers. Lung cancer, obviously. There's a specific chemical called benzoapyrene and other aromatic compounds in cigarette smoke that are now identified as the major carcinogens, at least for bronchogenic lung cancer. But cigarette smoking also contributes to other cancers. Oral cancer, laryngeal cancer, right? The guys who smoked 40 years, 3 packs a day, and now they got laryngeal cancer and they had a laryngectomy. It also contributes to esophageal cancer, gastric cancer, cancers of the nasal cavity and the sinuses, renal cell cancer, bladder cancer, so GU cancers, also cervical cancer, even some leukemias. So obviously, cancer, cigarette smoking are very closely linked, and it's not just lung cancer, lots of different cancers. Cigarette smoking can also increase your risk of peptic ulcer disease. It actually increases your risk of diabetes, and it increases your risk of ectopic pregnancy and other obstetric problems, which we're going to discuss below. So next question, what are the risks associated with smoking during pregnancy? So smoking causes structural changes of the placenta, such as reduced capillary volume, and this leads to abnormal gas exchange. Cigarette smoking may also lead to nicotine-induced vasospasm, and there may be direct toxic effects on the fetus from these hundreds of chemicals that you're ingesting. So again, it's not just nicotine. But smoking will increase your risk of spontaneous abortion. It will also increase your risk of placental abruption and placenta previa, and it will increase your risk of preterm labor and low birth weight. Next, a 25-year-old female patient presents with severe depression. She has no previous history of depression, but since attempting to quit smoking 2 weeks ago, she's had feelings of worthlessness and apathy. What medication might she be taking to help her quit smoking? Well, this is varenicline. Varenicline is associated with depression and mood changes and also increased suicidal thinking. Next, match the following drugs with their mechanism of action. So the methylxanthines antagonize adenosine receptors. Nicotine binds to nicotinic acetylcholine receptors in the CNS, obviously, and it activates sympathetic nervous system and releases epinephrine. Cocaine inhibits the uptake of dopamine, serotonin, and norepinephrine. And varenicline is a partial agonist of nicotinic acetylcholine receptors. Next, why are beta blockers not used to treat cocaine-induced hypertension? Well, cocaine causes tachycardia, so you might think that a beta blocker would be a good idea, right? Well, in the heart, stimulation of beta-2 receptors causes some coronary vasodilation, so that's a good thing. But if you give a beta blocker, you're going to block that good beta-2 vasodilation, and all you have left over is the unopposed alpha-1 vasoconstriction. So if you give a beta blocker to someone taking cocaine or having a cocaine-induced hypertension, you're going to blockade that good beta-2 vasodilation. You're going to get vasoconstriction of the coronary arteries mediated by the alpha-1 receptors. And you can also get end-organ ischemia because you have not just coronary vasoconstriction but peripheral vasoconstriction due to alpha-1 stimulation. So instead of a beta blocker, you give an alpha blocker like phentolamine. Now what about labetalol? I mean, that's a beta blocker and an alpha blocker, right? Well, it is, but it's much stronger a beta blocker than it is an alpha blocker. So don't use labetalol either. Stay away from beta blockers altogether. Actually, the first-line treatment for cocaine overdose or cocaine cardiotoxicity, cardiovascular toxicity of any kind, including hypertension, is a benzodiazepine. And so that's the first-line treatment for cocaine-induced hypertension. That's the end of the quick review. Now let's go back to Dr. Lewis.
Next, let's move on to the amphetamines. So the amphetamines are a group of synthetic, indirect-acting sympathomimetic drugs, and they will cause the release of endogenous biogenic amines. And these are dopamine and norepinephrine. So this is different than cocaine. So cocaine decreased the reuptake of the dopamine and norepinephrine. And the amphetamines are achieving its effect by releasing intracellular stores of the catecholamine. So we're actually secreting more of the catecholamines as opposed to just decreasing the reuptake. So the effects end up being very similar to cocaine. So let's talk about the central nervous system effects. So you get increased dopamine and norepinephrine. So this will stimulate the CNS, leading to an increase in alertness, decreased fatigue, depressed appetite, and you can also get insomnia. You get sympathetic nervous system activation. So like cocaine, it can upregulate the adrenergic system, so it results in tachycardia, hypertension, palpitations. So what are the therapeutic uses of the amphetamines? Well, unlike some of our other medications, there's actually some legitimate uses for these medications. And the first thing we need to talk about is attention deficit hyperactivity disorder, or ADHD. It's a very, very common thing. And as a primary care doctor or as a psychiatrist, you'll run into this daily. So it's characterized as an attentional problem with hyperactivity for 6 months or more. Now, the symptoms need to start before the age of 7, so this is mainly a pediatric problem, but you're going to see it quite often in the adult population as well. Now, it must impair function in either an academic setting or a social or occupational setting. And depending on the diagnostic criteria, and this will vary widely with studies, the prevalence is somewhere between 2 and 18% of our school-aged children. Now, the increased levels of dopamine in the brainstem, in the midbrain, and the frontal cortex are thought to be responsible for the increased attention span and concentration that occurs in the children with ADHD who take amphetamine medication. Now, the major medicines that we use are methylphenidate, dexmethylphenidate, and dextroamphetamine. And these are the most commonly used medications. Now, the side effects can be significant. The first one are GI side effects. So kids and even adults can get abdominal pain, they can get anorexia, they can get insomnia and nervousness. And this is important. Now, we have kids who are already a little distracted, maybe they don't eat as well as they're supposed to, and then we give them an appetite suppressant like methylphenidate. And oftentimes you'll see children lose weight. So when you are implementing this type of therapy, you need to be very careful to check weights every time they come in for their follow-up, for their refills. Another medication that's a non-stimulant drug used in ADHD is atomoxetine. And this works only on norepinephrine reuptake. Now, Our amphetamines, we're working more on dopamine, and this is more on norepinephrine. It doesn't have the same problems with addiction or euphoria, because remember, dopamine is our euphoria system. Other clinical uses for amphetamines. Next is narcolepsy, so uncontrollable sleeping bouts during the day. Sometimes this can be associated with cataplexy or a complete loss of muscle tone. The amphetamines can help because it can improve wakefulness, so it wakes up a narcoleptic. Now, there are a couple of medications that are used other than the typical amphetamines. So modafinil and armodafinil are newer drugs, and they're used for narcolepsy as well. Their mechanism is a little unclear, but it might involve the adrenergic and dopaminergic systems. Now, you get less euphoria, but it's still working on some of that dopamine, and so there's still some potential for abuse, so you need to watch out for that. Next, let's talk about the pharmacokinetics of amphetamines. So they can be absorbed from the GI tract, but abusers tend to want to take amphetamines or methamphetamines either by IV or by smoking, because it gets into their system quicker and it gives them a higher high. So the euphoria will last upwards of 4 to 6 hours. Now, if you remember, cocaine was only lasting us 1 to 1.5 hours. So that's one reason why the methamphetamine craze has gotten so big, is that one, these are relatively cheap drugs and they last quite a long time. Now, they're metabolized in the liver and they're excreted in the urine. Next, let's talk about the adverse effects of amphetamines. So these are highly addictive medications like our other stimulants. Intolerance is very common, so you have to take more of the drug to get the same effect. So for the central nervous system, it'll affect you by giving you insomnia. You'll hear of meth addicts who don't sleep for days on end. You'll get irritability, weakness and dizziness, tremor, hyperactive reflexes. More seriously, you can get confusion and delirium. Methamphetamine addicts will be in panic states and even can get to the point of suicidal tendencies. Overdoses can be treated with chlorpromazine or haloperidol, and this can relieve the CNS symptoms, but it's also got some benefit because it can help the hypertension that's caused by alpha activation, because those two medications can help block the alpha receptors. So for cardiovascular, it's similar to the other stimulants like cocaine. You'll get palpitations, cardiac arrhythmias, hypertension. You can get anginal pain. For gastrointestinal, you can get anorexia, and we talked about that before with our legally used amphetamines. Nausea, vomiting, and diarrhea is also common. It's contraindicated in patients with hypertension, obviously, and cardiovascular disease. It's contraindicated in patients with hyperthyroidism or glaucoma. And obviously, you don't want to use this in patients with a history of drug abuse because of the addiction potential. Next, we're going to switch gears to ecstasy, or MDMA, or methylene dioxymethamphetamine. Now, there's no legal version, no clinical reason to use these medications, but it's very popular, and it is similar to our other stimulants, and you should know something about them. So this class of drugs are a synthetic derivative of the methamphetamines, and they foster feelings of intimacy and empathy, but they don't impair intellectual capacity. So like the amphetamines, it'll cause a release of the biogenic amines, and it reverses their transporters. So it has a strong affinity for the serotonin transporter, and therefore it can increase the extracellular concentration of serotonin dramatically. After taking MDMA, these can produce a marked intracellular depletion of serotonin. So you're just dumping all your serotonin into the extracellular space, and you can lose all your intracellular serotonin for upwards of 24 hours. So the concern is that if you are using your ecstasy repeatedly, that you could lead to a potential permanent depletion of your serotonin, and that wouldn't be very good for your mood. So the adverse effects. So like cocaine, you can get hyperthermia. And this is made worse because socially, ecstasy is used in rave situations. So sometimes people will go out into the desert, which is obviously a dry place. They'll dance all night, get dehydrated, and also the drug will cause hyperthermia. So there was some education that told the ravers you need to drink more water while you're tweaking out in the desert. And unfortunately, the ravers followed that direction a little too well, and they started drinking too much water. So then in the ER, you'd get your ravers who are strung out on ecstasy, and they're also hydrated, so they got hyponatremic, and then unfortunately, sometimes this can lead to seizures and death. Those poor tweakers. So serotonin syndrome is also a possibility. You can get mental status change, autonomic hyperactivity, and neuromuscular abnormalities. And then withdrawal, you can get depression. So we're dumping out all of our serotonin into our extracellular space. So you can get depression, and this can last for weeks. Now we're going to move to a different type of stimulant. These are the hallucinogens. So the first one is LSD, or lysergic acid diethylamide. So this is a serotonin agonist, and its activity is on the presynaptic 5-HT1 receptors in the midbrain. It's also working on the 5-HT2 receptors. Now, when this drug is taken, you get this altered consciousness. You get great euphoria, increased sensory awareness, perceptual distortions, and increased introspection. Sounds like a great day to me. So after these are synthesized in a lab, they're usually sprinkled, the liquid is sprinkled on blotter paper, or it's also sprinkled on sugar cubes and allowed to dry. Now, the psychoactive effects appear after about 30 minutes and can last upwards of 6 to 12 hours. The typical adult dose is about 20 to 30 micrograms, but this can be quite variable depending on how many drops get dropped on some blotter paper somewhere. So this can lead to also strong contractions of the uterus. So this has been known to cause abortions in female patients who are taking LSD. Now you do get, again, activation of your sympathetic nervous system. So side effects will include tachycardia, pupillary dilation, increased blood pressure. Now, fortunately for our LSD addicts, there's actually no dependence or addiction, so I don't know if we can even call them an addict. But tolerance does occur, and it does cause, obviously, a lot of medical problems. Next, we're going to move on to THC, or tetrahydrocannabinol. So this is the active ingredient in marijuana, and this can cause euphoria and drowsiness and relaxation. And you get this binding of the cannabinoid receptor CB1, and this is located mostly in the central nervous system. There's binding of CB2, but this is mostly located in the immune system, and we're not really sure if that's really clinically significant. Now, there are some adverse effects to THC, and that's dysphoric state. So not everyone has a great time smoking marijuana. Sometimes you get dysphoria. You can get increased appetite, so you can get the munchies. High doses can actually lead to visual hallucinations. Now, there is a legal and prescription version called dronabinol, and this is available for prescription, and it's indicated for patients with AIDS who are having problems with wasting or losing weight. It gives them the munchies, so they get a little more hungry and want to eat more. People who are undergoing chemotherapy can use this medication to help decrease their nausea. But again, this isn't used clinically that often. We've got a lot of good anti-nausea medications that work better than this. Rimonabant is a CB1 receptor antagonist, so it's the opposite of THC. And it can be used as an anti-munchie drug. So it's used to help treat obesity, to help decrease their appetite. Though it can cause anxiety and depression, and it's really not used very often at all. It was used outside of the United States to some extent for obesity, but I think even now it's been used less and less. Finally, we're going to talk about PCP, or phencyclidine. Now, after you take PCP, you're going to get hallucinations. You can get an out-of-body experience. So, this is achieved by, one, an inhibition of the reuptake of dopamine and norepinephrine, but the more major action is a blockage of NMDA subtype glutamate receptor. So there's a NMDA subtype glutamate receptor that gets blocked by PCP. Now, PCP is an analog of ketamine, and ketamine is still used as an anesthetic. You'll hear about ketamine being used for burn victims when they have to go through peeling off their skin. They'll give pediatric patients and sometimes adult patients ketamine to help them cope with the with the pain, and they often don't remember any of those episodes either. So you get a dissociative anesthesia, so you get an insensitivity to pain without a loss of consciousness. You can get numbness of the extremities, you get a staggered gait, a slurred speech, and muscular rigidity, which is important to remember, and also good for testing hypersalivation. So if you have a patient who comes in who's got a lot of spit coming out of them, they're foaming at the mouth, you might want to think about PCP intoxication. And you can get some really bizarre behavior with PCP. You'll have people who really just lose their bananas when they're on PCP. Again, luckily for our PCP users, there's no major dependence and there's no major addiction or withdrawal, but it does give you a lot of just really bizarre behavior, and it doesn't seem like a good time to me.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
What are the three main therapeutic uses of amphetamines? Treatment of ADD, treatment of narcolepsy and related sleep disorders, and treatment of obesity. Now, cut the suture. Cut! That's too long. Cut it shorter. Not so short! What's wrong with you?
All right, now it's time to go through the answers for Quick Review 2 in your study guide. First question, what are some therapeutic uses for amphetamines? So amphetamines are used to treat ADHD, they're used to treat narcolepsy, and they're also used as appetite suppressants to treat chronic obesity. Next, list some characteristics of ADHD. So ADHD can be associated with limited attention span and poor impulse control. It can be associated with onset before age 7. It's characterized by hyperactivity, motor impairment, and emotional lability, and it's associated with decreased frontal lobe volumes. Next question. An 8-year-old female is brought to the clinic to discuss treatment for her ADHD. She has never been treated for ADHD in the past, but now she's unable to function appropriately at school. The patient's parents do not want to use any of the usual stimulant medications. What medication may be appropriate in this situation? Well, the most appropriate medication in this situation would be atomoxetine. It has less stimulant effect and very little abuse potential, so it's very safe. Next, list some adverse effects of amphetamines. So amphetamines can cause vertigo, they can cause hypertension, they can cause insomnia. That's why they're used to treat narcolepsy. They can cause confusion, GI problems such as nausea and diarrhea. They can cause decreased appetite, and they also have potential for addiction. Next, methylphenidate can interfere with the metabolism of what medications? So methylphenidate will interfere with the metabolism of warfarin, phenytoin, phenobarbital, primidone, and tricyclic antidepressants. Next, besides cocaine, what other drug can cause hyperthermia? Well, this is ecstasy, or MDMA, or I love the long name, methylene dioxymethamphetamine. Just rolls right off the tongue, doesn't it? Next, what are some signs and symptoms of LSD intoxication? So LSD intoxication can cause marked anxiety or depression. It can cause delusions and obviously visual hallucinations. You can also have pupillary dilation. Next, what are some signs and symptoms of PCP intoxication? PCP intoxication can cause belligerence, impulsiveness. It can cause nystagmus, both vertical and horizontal nystagmus. You can get tachycardia, ataxia, homicidality, also psychosis and delirium. Next question, what are some withdrawal symptoms from marijuana use? So withdrawal from marijuana can cause irritability, it can cause depression, it can cause insomnia, it can cause nausea and anorexia. I mean, think about it, it's just the reverse of marijuana intoxication. With intoxication, you get the munchies. With withdrawal, you get anorexia and nausea. Most symptoms from marijuana withdrawal will peak in 48 hours, and they may last for 5 to 7 days. And metabolites of marijuana can be detected in the urine up to 1 month after the last use. So that's the end of the quick review. Now it's a good time to pause the video and answer the end of session quiz questions, and then restart the video and we'll go through these answers. Okay, let's go through the answers to the end of session quiz. Number 1, what are the mechanisms of action of the following CNS stimulants? So caffeine blocks adenosine receptors. Cocaine blocks the reuptake of catecholamines in the presynaptic terminals. Amphetamine increases the release of catecholamines from the presynaptic terminals, so the effects of it are very similar to cocaine, but the mechanism by which it achieves that effect is very different. And then nicotine, in low doses, nicotine causes ganglionic stimulation by depolarization. At high doses, nicotine actually causes ganglionic blockade. Next, match the following clinical descriptions with the most appropriate therapeutic agent. So a 55-year-old woman with no past psychiatric history wants to quit smoking. So varenicline might be a good choice for this patient. You might use bupropion if she had a history of some depression, or if she had a history of suicidality, you might not want to use varenicline because that can increase suicidality. The next one, a 32-year-old narcoleptic patient needs something to stay awake in the day. This would be a good patient to use modafinil in. The next one, a 40-year-old woman is undergoing rhinoplasty and needs local anesthesia. We use cocaine for local anesthesia during some ENT surgeries. And then a 10-year-old boy with ADHD needs medicine to help him focus. This would be a great patient to use methylphenidate. Next, name the common potential adverse effects most likely to occur with nicotine. In low doses, nicotine can cause euphoria, arousal, relaxation, increased attention, and learning and problem solving. It can also cause appetite suppression. It can increase your blood pressure and heart rate, and it can increase bowel movements. In high doses with nicotine, you can get respiratory paralysis and also hypotension. Varenicline includes suicidal thoughts, as we've mentioned, vivid dreams and nightmares, and also mood changes. And with methylphenidate, you can get abdominal pain and anorexia, and also insomnia and nervousness. Next question, what medications would you consider using on a patient with narcolepsy who wanted a medication less likely to cause addiction? So you could use modafinil or armodafinil. Next, compare the symptoms of PCP intoxication to those of LSD intoxication. So with PCP, you get hypersalivation, you can get muscle rigidity, you may have insensitivity to pain, the eyes will remain open, and you can get bizarre behavior and aggression, psychosis, delusions, that sort of thing. With LSD, you can get anxiety, pupillary dilation, fever, and muscle weakness. Next, what medications are useful in smoking cessation? So we've already mentioned varenicline. That's the newest one on the block. There's also bupropion, which has been used in a couple of different forms to help with smoking cessation. And then also nicotine replacement, whether it be nicotine gums, patches, inhalers. Those are all useful to treat smoking cessation. Next, what's the treatment for hypertensive emergency in cases of cocaine overdose? We mentioned this in the quick review. Benzodiazepines are your first-line drugs. Phentolamine can be used as an adjunct to that. It's an alpha blocker. You want to avoid beta blockers. Next, how does the mechanism of action of atomoxetine differ from that of methylphenidate? Well, unlike methylphenidate, which blocks dopamine reuptake, atomoxetine is a norepinephrine reuptake inhibitor. Now, these drugs are not amphetamines. They don't cause catecholamine release like the amphetamines do. They block reuptake, so they function a little bit more like cocaine, but they're used like amphetamines for the treatment of ADHD. Next, what's a potential permanent problem with long-term ecstasy use? So long-term ecstasy use may be associated with permanent depletion of serotonin, and that could lead to depression. Next, a 22-year-old male presents to the emergency department after having a seizure. He has no past medical history of epilepsy. His friends report that they were using ecstasy and have been partying all night. His glucose level is 100. He shows no signs of dehydration. So what could be a possible cause of this patient's seizure? Well, the answer we're looking for here is hyponatremia. So there are a lot of different reasons why ecstasy can cause hyponatremia. You sort of get this perfect storm of bad things going on. First of all, we tell patients if you're going to use ecstasy, we tell them not to use it, but if you're going to use it, you might get hyperthermia, you might get dehydrated, so drink lots of water. So these patients sometimes will overindulge in water. They're at parties, there's plenty of fluids around, so they just drink lots of water intentionally. and that can dilute the serum and lead to hyponatremia. Now you have to drink a ton of water to do this. Your kidneys are pretty good about handling excess water intake, but you can overcome the kidney's capacity to get rid of all that excess free water, and so you can get hyponatremia. Ecstasy use may also be linked to increased secretion of ADH, or vasopressin. So you get a syndrome of inappropriate ADH, or SIADH. And this will lead to hyponatremia. Ecstasy may also stimulate the thirst center via serotonin. So there's lots and lots and lots of different ways that ecstasy can cause hyponatremia through excess water intake and excess water retention. So that's the end of session quiz, and